Thank you, Jyoti, for having me here this morning. So I'll be talking about pachychoroid disease, macular neovascularization in pachychoroid disease, and this is very important because this forms a substantial portion of our patients in a neovascular AMD clinic. So before we go into the actual talk, we have to understand what are the various phenotypes and presentations. So pachychoroid per se is not a disease, but pachychoroid epitheliopathy is a disease. And what we are going to talk about is a nascent or a non-exudative pachychoroid neovascularization and the type 1 macular neovascularization and CSCR with macular neovascularization and PCV. So these are the four entities which we are going to talk about. And before we start that, I thought I'll just educate some of you about what exactly is pachychoroid disease. So this is a classic case of a pachychoroid disease from one of my patients where you can see these sort of small extensive RP abnormalities. These are not truly drusenoid, but these are basically RP abnormalities which you see in both the eyes. And when you do the OCT, you see these sort of changes. One is a significant increase in the choroid, significant increase in the hallux layer, and there is a compression of the inner choroid, and you can see the retinal pigment epithelium abnormality. So this is classic pachychoroid disease for you. And here you can see the large vessel here and causing RP atrophy and outer retinal atrophy also. So these are all classic features of pachychoroid disease. And when you do an ICGA, you see that the watershed zone in the center is lost. You have these dilated veins right in the center of the macula. These are all classic features of pachychoroid disease, which you see in many patients presenting with central serous chorioretinopathy. With this background, we go on to our cases. This is the first case I want to show you. You see the left eye has got a vision of 6 by 45. The right eye has got a vision of 6 by 6. And when you see the left eye, he's got a classic chronic central serous chorioretinopathy. He's got a very thick choroid and he's got these cystoid changes. The visual acuity outcome is quite poor. But when you see the fellow eye, he's got again a pachychoroid disease and he's got this classic RP abnormality, which is very, very important. And when you do the octa, you see the silent macular neovascularization. When you do octa, you have to segment it. Manual segmentation is very important so that you're able to see this particular area in the octa to detect this abnormal neovascular network. Therefore, this patient was followed up regularly. And if you see the serial octa over a period of time, you see the network growing here. You see the network growing here. You see the previous one. You see this one. And finally, about 2.5 years later, the patient developed active disease in the fellow eye, for which intravitreal anti-VEGF agents were started. Aflibercept is the most acceptable or probably the best medicine to start with in such a clinical situation. So the purpose of showing this particular case is whenever you see a patient with CSCR, especially in the elderly, please look into the OCT very carefully, especially the fellow eye, and you may be having a silent macular neovascularization, and these are patients who need very regular follow-up. This is case number 2. Now, this particular patient also, if you see the color photograph, you see this RP dysfunction, and when you see the OCT, the autofluorescence, it looks like a chronic central serous chorioretinopathy. You see this particular OCT of the left eye. This patient, you can see here, he's got just a serous macular detachment. But then when you carefully see the retinal pigment epithelium, you see those small elevations that come in during the period of the OCT. So this tells you that, look here, this is not just a CSCR. If you do a FFA, you see this suspicious leak here, and you see all these small areas of staining. And when you do the ICGA, you see these dilated vessels. And when you do the octa, you see this neovascular network. So this is actually not a central serous chorioretinopathy, but this is a CSCR-like picture with a macular neovascularization. So basically, when you are using octa, I think you should understand what are the various types of octa pictures. And I would like all of you to read this particular article, a very good article to educate you about octa. You should know what is this type of octa, where you have the central trunk, and what you have in this particular picture, where you have a very hypermature neovascular membrane, which is not going to be very active. So this particular patient was initially treated with ranibizumab. Unfortunately, ranibizumab is not a good responder for these sort of cases. And finally, the patient was shifted to aflibercept, with which he received a dry macula, and subsequently he has been under our follow-up. It's also important to understand what is a defining a tolerable fluid. So once you have treated some of these patients, and once your octa has shown significant reduction, in the smaller capillaries and you have this dead tree appearance and you have these sort of small residual fluids, probably you don't have to be very aggressive. So personally, I feel three things are important before you inject. One is the quantum of fluid. Two is symptoms of the patient. And three is what you see in the octa. So the octa is showing a dead tree appearance. There is very minimal subretinal fluid. The visual acuity is stable. We need not be aggressive in management. This is my next case. This again is a pachychoroid neovasculopathy. You can see this membrane here, a silent one, which progressed into a neovascular membrane. The reason why I'm showing you this particular case is this patient has been under my treatment for nearly 10 years, on irregular treatment for 10 years. So when you have a type 1 neovascular membrane, it's not something that's very active. It doesn't affect our vision much. And patients retain reasonably good vision over a period of a long time. Therefore, type 1 neovascular membrane does not require that aggressive a treatment. So this is a very important take-home message. So the next is the polypoidal choroidal vasculopathy, where, as I've been describing in many meetings, that there are two phenotypes. One is what I call as an aneurysmal dilatation, where you have this large neovascular branching neovascular network ending in polypoidal dilatations, which is less aggressive. So these sort of patients actually, if you see this particular patient who has been under my treatment for 5 years now, he was treated initially with 3 doses of aflibercept. He achieved complete polyp closure. And subsequently, over the period of next 3 years, he has just received 3 injections. So over a period of 4 years, he has just received 5 injections. He's still doing well. He's on a PRN-based treatment. And therefore, neovascular type of that is polypoidal neovascularization with a large network with less polyps responds better to treatment, does not require that much of aggressive treatment, and they will not usually present with submacular hemorrhage. So coming to the management of PCV, I still feel that PDT has a role. Combination therapy had already told us 2 things. One is increased rate of polyp closure. 2 is reasonably good maintenance of visual acuity. Today, the management is purely based on OCT morphology. But personally, I feel that polyp closure also is important because polyp closure gives us a long period of quiescence from the disease. So we are already presented multiple articles on combination therapy. And one of the important take-home messages that we showed is in at least half the patients who received combination therapy, at least for 24 to 36 months, they were free from treatment. That's a very important take-home message. So this is one of our old patients with a PCV. You can see here, cluster polyps, treated with 1 cycle of PDT in 2016. And after that, he came back with a recurrence in 2019, about 2.5 years later. Therefore, we used to get quite a long period of quiescence. And that also is a very important take-home message. And therefore, still in certain subgroups of patients with PCV, there is a role for PDT combination therapy. So coming to PCV management, this particular article is very, very important, the PLANET trial, that tells us about the role of aflibercept in PCV. This particular publication did not get much of importance when it was published, but in today's scenario, it's very, very important because it gives us 3 messages. One is the visual acuity maintenance was very good even after 24 months. Second is the need for injections substantially reduced in the second year. That is only 4.2 injections in the second year. Third is polyp closure was about 35%, which is probably less than the what we get in combination therapy, but better than any of the other molecules that we have today. Therefore, from that point of view, the use of aflibercept in PCV, the non-responders are only about 20%, and nearly 75% of patients with PCV do respond to aflibercept. This again is a very important article where they have shown that with good intensive treatment at 8 weekly intervals, at the end of 1 year, with aflibercept, you can achieve 50% polyp closure in polypoidal disease. Therefore, having said all that, let us look at some of the non-responders. So this is one of my patients who has been under my treatment for a couple of years now. Now he's got what I call as the cluster polyps. Now these are the most dangerous polyps because they can bleed, they're more difficult to treat, and they are very resistant to anti VEGF treatment. Now this particular patient received monthly doses of aflibercept. Monthly dose of aflibercept with very poor response, you can see here. He was shifted to, and if I repeated the ICGA, slight reduction in the number of polyps, but still very active. Shifted to faricimab. The response was quite good. After 3 doses of faricimab, there was reasonably good response. But unfortunately, and if you see the ICGA, there is good response again. The polyp closure is there. Fortunately, the patient came back with a recurrence within 6 weeks after the last injection, and this time the recurrence was even worse. And subsequently, he has been on monthly dose of faricimab. Therefore, this is a patient who has shown poor response to anti-VEGF injections. And if you look at this particular article, they have defined the poor responders based on OCT in PCV, looking at this huge thumb-shaped or pointed PED with this you see this vacuole sign right at the roof. And if you look at this, my patient here, if you look at the first OCT, you see here, he has got a similar picture. So these are patients you can diagnose even based on OCT to tell you these are patients who are probably going to be very resistant to the management with anti-VEGF agents. So this is another patient of mine. Here you can see here, this particular patient again has got an aneurysmal type of a polypoidal disease. This is the picture. He was managed as CSCR elsewhere for quite some time, but this is not a CSCR. This is polypoidal disease. And if you see the ICG, he has got an aneurysmal dilatation. But then if you look at the response to anti-VEGF, he was initially put on Eylea, 5 doses of Eylea, but unfortunately not much response at all. And more importantly, the neovascular network was growing in spite of the anti-VEGF agents. Therefore, when you see the neovascular network growing in spite of the anti-VEGF agent, so when you start treatment, if you have OCTA, you do a baseline OCTA. And then you can repeat the OCTA after 3 or 4 injections, because that tells you what is the change in OCTA apart from the morphological changes in OCT, and this gives you a plan on the treatment. If the response is not good both ways, that means the drug is not really working. So this particular patient, in spite of multiple doses, finally was shifted to faricimab, and even faricimab did not work. Faricimab, but although the network is showing more of a mature network, fluid was quite persistent even after 5 doses of faricimab. And finally, I put him on 1 dose of brolucizumab, with which there was a dramatic response. Therefore, you can see here, there is just a mature network now, and the fluid is completely gone. So basically, someone may ask me, why did you wait so long to shift to brolucizumab? But then we look at safety and efficacy first, and safety is very important when we treat patients, and that's why there was a delay in using brolucizumab in this particular situation. Therefore, I would also like to highlight our experience with brolucizumab in the PCV. We have been using it as a rescue treatment for quite some time now, and we recently have published this particular series, or in the process of publication, of 32 patients with PCV who have been shifted to rescue faricimab, and our experience has been quite encouraging because basically, most importantly, the need for injection substantially reduced, and also the response to treatment was very good. And most importantly, the response to the polypoidal PED, which is very, very important. Always I tell my fellows, look at the polypoidal PED. The polypoidal PED has to reduce in height. And if it has reduced in height significantly, then you know that there is either a polyp closure or inactivation of polyps. So that's a very important sign. And that also responds very well to brolucizumab. So having said all this, what are the take-home messages? There are different phenotypes of MNV in pachychoroid disease. We need to understand that. I have also explained the role of OCTA and ICGA, both in diagnosis and follow-up. As far as the choice of anti-VEGF agent is concerned, based on safety and efficacy, aflibercept still continues to be the drug of choice. I have any financial interest. And when to switch, we know when to switch when there's no good response. And when we switch, I feel the best drug would be, based on current evidence, brolucizumab, and the benefits of combination therapy with vertiforce and quality should be kept in mind, especially in patients not responding to anti-VEGF therapy in PCV even today. Thank you.
Thank you, sir, for that extensive masterclass in managing NV AMD and the pachychoroid